I had an observer in the reading room, Yassine Alami, who told me that if I did this lecture, it would become the most popular lecture on my YouTube site. So let's find out. We're going to talk about the radiologic anatomy of the skull base, and we're going to go from front to back, and we're mostly going to be focused on CT so we can talk about the bony structures. So these are the topics we're going to hit from front to back: the roof of the nasal cavity, then we'll go back to the planum and the sella, and we'll talk about the pterygoid plates and the Pterygopalatine fossa. We'll talk about all the foramina and the central skull base. We'll focus a little bit on the clivus and then end up back at the occiput. When we're talking about the anterior skull base, we're talking about the roof of the nasal cavity, and it's a complex bit of bony anatomy. This horizontal piece of bone is called the cribriform plate. It's famous because it's got tiny little holes that the first cranial nerve sends projections down through so that we can smell. This parallel piece of bone, also horizontally oriented, is the fovea ethmoidalis, the roof of the ethmoid air cells. Connecting these two is the lateral lamella of the cribriform plate, the lateral lamella. It's a vertically oriented bone of variable length that connects the cribriform plates to the fovea ethmoidalis. When we talk about how deep the cribriform plates are, we're really talking about how long the lateral lamella is. Right down the middle, dividing things in half, is the crista galli. This is the anchor point for the falx cerebri that's going to come up from there. So we've talked about the bony structures. Let's focus now on the spaces. Above the cribriform plate is the olfactory groove where the first cranial nerve is running. Below the cribriform plate is the olfactory cleft, or sometimes olfactory recess. Those are synonyms. So olfactory groove, olfactory cleft on either side of the cribriform plate. The olfactory groove should be filled with a nerve and mostly CSF, and the olfactory cleft should be filled with air, although sometimes mucosal thickening will opacify it. Now, one of the things we're looking for in the anterior skull base are gaps, erosions in all of the bones we've just been talking about. But there are some permissible gaps, in particular the anterior and posterior ethmoidal arteries. Of the two, the anterior is a little larger and more easily seen. The anterior ethmoidal artery runs between the orbit, crosses the top of the ethmoid air cells, and then pierces through the lateral lamella. This is normal anatomy. When you see this gap in the lateral lamella, don't call that an erosion or a CSF leak. That's normal anatomy. Usually you can trace it all the way back to the orbit like this. Moving more posteriorly, if the roof of the ethmoid air cells is the fovea ethmoidalis, then the roof of the sphenoid sinuses is the planum sphenoidale. And in fact, this is continuous bone. The ethmoid air cells continuous with the sphenoid sinuses, the fovea ethmoidalis continuous with the planum sphenoidale. This is what it looks like in the axial plane. These are the sphenoid sinuses, that's their roof, but it's sometimes easier to appreciate in a sagittal reformat. So here's the planum sphenoidale in sagittal, right? These are ethmoid air cells here. These are sphenoid sinuses, so the roof of the sphenoid is the planum sphenoidale. How do I know that this is a sphenoid sinus and not a posterior ethmoid air cell? I can see it draining into the sphenoethmoidal recess. If we go further back, the sella turcica is where the pituitary lives. We'll talk more about the walls of the sella turcica. Notice that the sphenoid sinus can pneumatize to a variable degree up and around the sella turcica. Sometimes the sphenoid sinus barely reaches the sella turcica. Sometimes it goes halfway around, like in this case. Sometimes it pneumatizes all the way up through the top of the clivus into the dorsum sella. Dorsum sella is this part of the sella turcica into the dorsum sella, and all of those are normal. Those are normal variations in pneumatization of the sphenoid sinus. The clivus is this triangular bone, at least it's triangular in the sagittal projection, and we'll talk about that more in a little bit. An important bone of the greater sphenoid wing is the anterior clinoid process. This projects out along the lateral aspect of the optic canal, and it sort of points towards the pituitary gland, or really more towards the suprasellar cistern from either side. That's the anterior clinoid process. Anatomy of the anterior clinoid process can sometimes be confusing. Notice this little round area of signal void adjacent to the siphon of the internal carotid artery. That could easily be taken to represent an aneurysm off of the internal carotid artery. See it on CT, the answer is obvious. That is pneumatization of the anterior clinoid process, not an aneurysm. The posterior clinoid process is the partner of the anterior clinoid process. The posterior clinoid process arises from the lateral aspect of the dorsum sella. This is the sella turcica, here's the dorsum sella, and these are the posterior clinoid processes on either side. The anterior and posterior clinoid processes point at one another, and they form a cage around the pituitary gland. Let's talk about some of the structures surrounding the area we've been talking about. What's nearby? The carotid artery, the pituitary gland, the optic canal, the nasolacrimal duct, the orbit, hard palate, and pterygopalatine. These two pretty clear and not really what we're talking about today. The pterygopalatine fossa we'll dive into in more detail in a moment. So let's talk about these four. Now here I've specifically chosen a patient with a lot of atherosclerotic disease in the carotid arteries so that they're easy to see on an unenhanced scan on bone window. These are the anterior clinoid processes, and you can see the internal carotid arteries wrapping up and around, the siphon twisting around those anterior clinoid processes. Notice the proximity of the internal carotid artery to the sphenoid sinuses here. And in fact, with pressure erosions, you can thin the wall of the sphenoid sinus adjacent to the internal carotid arteries. That is important to mention radiologically because you don't want a surgeon to accidentally go through that gap. The pituitary gland in its expected location adjacent to the sphenoid sinus at the top of the clivus, surrounded by the sella turcica. Okay. And now the optic canal. The optic canal, medial to the anterior clinoid process and lateral to the sphenoid sinuses. Here is the optic canal. Now you might say, this looks like exactly the same location as the internal carotid artery that you just showed. And in fact, these are very similar in location. These are neighbors to one another. The optic canal tucking just right under the anterior clinoid process. The nasolacrimal duct runs from the medial orbit down to the inferior meatus. It may be filled with tears, it may be filled with air. Those are both normal. Now let's turn our attention to the pterygoids and the pterygopalatine fossa. The pterygoid plates are perhaps easiest to see in the coronal plane, where you can see the medial and lateral pterygoid plates. They come together at the base of the pterygoid, and that connects up to the skull base. Pterygoid plates are pretty straightforward, but the pterygopalatine fossa is not. The pterygopalatine fossa is a crossroads for a variety of nervous structures that are running through the skull base, and its anatomy is complex but worth understanding. The main item in the pterygopalatine fossa is the pterygopalatine ganglion. It receives most of its input from Vidian's nerve, which dead ends into the pterygopalatine ganglion. It's a branch of the seventh cranial nerve, Vidian's nerve. It also receives a lot of innervation from the second branch of the fifth cranial nerve, from V2, the maxillary nerve. But V2 doesn't dead end into the pterygopalatine ganglion. It runs just above the pterygopalatine ganglion, sends some feeders, receives some information back, and continues on its way. The major content of the pterygopalatine fossa is fat. Perhaps the most important content is the ganglion, but most of the content is fat. And the imaging appearance of the Pterygopalatine fossa is dictated by the fact that it is mostly filled with fat. It's important to understand the surrounding structures, the surrounding anatomy of the Pterygopalatine fossa, including the sphenopalatine foramen, which leads from the Pterygopalatine fossa into the nasal cavity, and the pterygomaxillary fissure, which leads from the Pterygopalatine fossa out laterally into the infratemporal fossa. We'll talk more about those. So here's the pterygopalatine fossa. How can you find this thing if you're looking for it? Find the maxillary sinus. Go to the very middle of the maxillary sinus on an axial image, and the pterygopalatine fossa will be right behind the maxillary sinus. Notice that, as advertised, it is predominantly filled with fat. It's not exclusively filled with fat. There's a ganglion in there. There are arteries and nerves, the sphenopalatine artery, running through the pterygopalatine fossa, but it's mostly filled with fat. Here's the same concept on MRI, on a T1 weighted unenhanced image without fat suppression, all that fat lighting up in the pterygopalatine fossa. Here we are right in the middle of the maxillary sinus, center of the maxillary sinus, right behind that, there's our pterygopalatine fossa, mostly filled with fat. So let's talk about the pterygopalatine fossa and what's nearby. So this fat right here is the pterygopalatine fossa. And what's in all the cardinal directions? Well, if you look just above, just superior to the pterygopalatine fossa, you'll see the inferior orbital fissure. That's where V2 is running. When I said that V2 is just visiting and sending down some communications, that's where it's visiting from. And there are small nerves communicating between the two, but it's just going to continue on above the pterygopalatine fossa. If we look inferior to the pterygopalatine fossa, we're going to see the base of the pterygoids and the pterygoid plates if we looked a little more posterior. What about medial? Well, here is the entryway between the pterygopalatine fossa and the nasal cavity. That's the sphenopalatine foramen. It's famous because juvenile nasal angiofibromas arise in this location, for example. If we go laterally instead, there's the pterygomaxillary fissure. It is the opening that communicates between the pterygopalatine fossa and the infratemporal fossa out here. So if we're going to summarize what I just talked about in a text slide, superior to the pterygopalatine fossa is the inferior orbital fissure. Inferior to the pterygopalatine fossa is the pterygoid plates. Medial is the opening medial is the sphenopalatine foramen. The opening lateral is the pterygomaxillary fissure. Now, on that coronal cut, I couldn't show you anterior and posterior, but anterior to the pterygopalatine fossa, as we've been discussing, is the mid portion of the maxillary sinus. And posterior is Vidian canal. Remember, the Vidian nerve, which is inside the Vidian canal, is dead ending straight into the pterygopalatine fossa. So here's what that looks like on a coronal image. Right now, we are just posterior to the pterygopalatine fossa, just posterior. And on this coronal cut, you can see two round objects. One of these is the Vidian canal containing the Vidian nerve. The other is foramen rotundum containing V2. And the classic radiologic question is, which is which? Well, if you know that anatomy where V2 is running just above the pterygopalatine fossa, whereas Vidian's nerve is dead ending into the pterygopalatine fossa, you know that this has to be Vidian's canal because it's going to dead end, and this has to be foramen rotundum because it's going to skim above the pterygopalatine fossa. Notice that sometimes the sphenoid sinus will extend in between the two of these. And in fact, if you get enough pneumatization, it will even look like Vidian's canal is sitting atop its own little stalk or antenna as it gets pneumatized all around by the sphenoid sinus. All that's normal. But it can be very important to let your surgeons know about these relationships in this anatomy if they're going to do an expanded intranasal approach into this region. Here's the same anatomy as seen on the axial plane. This very long tube here, that is Vidian's canal. And here it is, boom, dead ending into the pterygopalatine fossa right behind the center of the maxillary sinus. Vidian's canal. Notice how long Vidian's canal is. Notice how small and thin Vidian's canal is. And notice how far down it is. We're really way down along the skull base here. This is foramen rotundum. It is less than a centimeter long. It's a very short tract. That's why we call it a foramen instead of a canal. And it doesn't look very round in this projection, but that's because we're not cutting it in cross-section. It looks round only when you cut it in cross-section. Notice that we're further up here. Notice that we're not at the level of the Pterygopalatine fossa. This is not the middle of the maxillary sinus. This is not the Pterygopalatine fossa. This is the inferior orbital fissure. And that is foramen rotundum leading from Meckel's cave into the inferior orbital fissure. So how is all of this useful? Well, here's a situation where we have a CT, and you can see here's the pterygopalatine fossa filled with fat, just the way we like it. There's the sphenopalatine artery running through, but mostly filled with fat. And if you look at the other side, it's completely socked in, barely any fat left. That's because this is perineural spread of tumor, completely replacing the fat in the pterygopalatine fossa, an extremely important thing to recognize. Here's the same concept on MRI, right? This is the pterygopalatine fossa right behind the maxillary sinus, pterygopalatine fossa filled with fat on this unenhanced, non-fat suppressed T1 weighted image, just the way we like it, filled with fat. On this side, filled with soft tissue, the fat has been replaced, perineural spread of malignancy. This concludes part 1 of the lecture on radiologic anatomy of the skull base.